The team, I welcome the presenters, the team led by Professor Temiye, the hematology team at Luth, and also Dr. Akinsete, and Dr. Ojo, the neurosurgeon at Luth as well. And then the ATLANTIS Pediatric Hospital team, Dr. Valentine, KAYODE Valentine is going to be presenting on behalf of that team. And I thank in particular Dr. Dushote for kindly agreeing to stand in for Dr. Iletu, who is unavoidably absent today. Anytime I see the type of presentation today, and I see that is a result of collaboration and partnerships between different institutions, I'm excited because I think this is the way we need to go. And in fact, it is one of the cardinal objectives of this group of pediatricians in private practice to foster collaboration between institutions, private to private and private to tertiary institutions. Because the truth is that in a resource-poor environment, it is the best way to maximize resources. And so working in silos is not going to be that productive any longer. So I want to congratulate the team today for working together. I think that's what they've done. Just looking at the people that are presenting, for working together towards the purpose of giving the children that we look after the very best. So I'm excited to be here. I'm actually very happy to welcome everybody. Although I'm on holidays, I had to wake up early in order to join you. But I said to myself, nothing will stop me from witnessing this meeting firsthand today. So I'm really happy to be here, and I look forward to a very good presentation. So it's my pleasure to hand over to the coordinator, Dr. Dushote, to carry on with the program. Thank you very much indeed.
Thank you very much, sir, for the opening remarks and for the sacrifice to be here. Well, the moderator for today's meeting is Professor Temiye Anegbon, and a very good friend. He is a professor of pediatrics and with a forte in hematology oncology. So I'll just yield to him. Today's topic again is symptomatic thrombocytopenia and pediatric astrocytoma, concurrent or related clinical entities. And like I said, we have a group of specialists across surgery, pediatrics, presenting today. And like the chairman mentioned, is a collaboration of many centers. So Dr. Professor Temiye, please, over to you, sir. I can't seem to see.
I think Temiye has gone off. Please go ahead.
Okay. Thank you, sir. So what we would do, we also hold the agenda that's with me. So we have a case summary that will be done by Dr. ZBA. So can you please go ahead and present the case summary, and then follow after that, Dr. Temiye will speak after the doctor. Thank you.
Good afternoon, everyone. My name is Dr. Zebi Ebiwe. I'm one of the medical officers at Atlantis Pediatric Hospital. I just want to confirm, can everyone hear me?
Loud and clear. You are loud and clear. Thank you.
So I'll be taking the case summary. So Master AN is a 7-month-old male he's one of a set of twins who presented to our facility on account of fever of 2 days duration and a right subconjunctival hemorrhage 1 day prior to presentation. So the hemorrhage started as a solitary spot on the right eye and then graduated to 2 spots. And then the mom noticed a spot on the left eye. There was no history of trauma, no eye discharge. It was active and tolerating well orally. Milestones were appropriate for age and the immunization schedule was up to date. So the clinical and physical examination were unremarkable, except for a right conjunctival hemorrhage. Heart rate at presentation was 140 beats per minute, respiratory rate of 32 cycles per minute, temperature of 37.2, weight of 13.15 kg, and the height of 78 centimeters. BMI was 21.6. The OFC was 78 cm, 48 cm. Length for weight for age and weight for age were all above the 97th percentile. So a complete blood count was done, which showed a platelet count of 8,000, a hemoglobin of 9.9 gram per dl, and a total white cell count of 7,480, with 24.9% of neutrophils and 64.5% of lymphocytes. So a diagnosis of suspected immune thrombocytopenic purpura was made. He was then reviewed by the pediatric hematologist, who advised to observe the child, and a close follow-up appointment of 2 days was given. So on the scheduled 2-day appointment, the fever had subsided. However, the mom had discovered a bump on his forehead and there was bruising under the skin. He was still active and there were no other concerns. Clinical and physical examination were unremarkable, except for right conjunctival hemorrhage and petechia. So a repeat complete blood count done on that day showed a platelet count of 11,000, which was an upward trend from the initial of 8,000 2 days ago. So the mom was reassured and then given a 1-week appointment. However, 3 days after the last follow-up visit, he presented on account of vomiting of 3 episodes, increased amount of subconjunctival hemorrhage, increased sleepiness, and reduced activity. On examination, he was drowsy but arousable. He was afebrile, slightly pale, anicteric, acyanose, not dehydrated, nil peripheral edema. There was a conjunctival hemorrhage spot on the left eye. The heart rate was 132 beats per minute, respiratory rate was 42 cycles per minute, vesicular sounds were heard bilaterally. He was admitted to the intensive care unit. A complete blood count on admission showed a platelet of 29,000. A transfontanel ultrasound scan done showed an intracranial hemorrhage in the left ventricle and the left cerebral hemisphere of about 50 mil. He had a CT scan of the brain done, which showed a massive effect on the left side of the brain. So while in the ICU, he was nursed at 30 degrees head up. He was placed on nil per oral, commenced on intravenous fluids at 75% maintenance, intravenous dexamethasone at 0.15 milligram per kg every 6 hours, intravenous ceftriaxone 100 milligram per kg per day, intravenous omeprazole 10 milligram daily, and he received apheres platelet concentrates at 10 mils per kg. A repeat complete blood count showed a platelet of 82,000. He was then transferred to a neurosurgical facility for expert care and management by the pediatric neurosurgeons. During his stay in the ICU, he was euglycemic. The heart rate ranged from 79 to 112 beats per minute. Respiratory rate ranged from 36 to 42 cycles per minute. Oxygen saturation was 100%. At the time of referral, he had a modified GCS of 13/15. 7 days from the initial presentation, he had a craniotomy and excision of a cystic and intracystic component of the lesion, query a pilocytic astrocytoma. Intraoperative findings indicated a left parietal lesion with an intracystic mass and elevated intracranial pressure. Following surgery, he was admitted to the intensive care for post-op monitoring and he received intravenous fluids, antibiotics, and analgesia. He was extubated 12 hours post-op and was doing well post-extubation until 16 hours post-op when he was noticed to be having unilateral jerky movements of the upper left lower limb, prompting initiation of intravenous phenobarbital. So at 48 hours post-op, He experienced severe abdominal breathing and a generalized tonic-clonic seizure with bradycardia and desaturation. Immediate CPR was initiated, followed by, sorry about that. So immediate CPR was initiated, followed by IV atropine administration. And then a subsequent brain MRI revealed residual tumor, necessitating a repeat craniotomy and an excision of the residual tumor 3 days after the first craniotomy. He was then transferred back to our facility 48 hours post-op for continuation of pediatric care. So on presentation, during examination, he had a 6 cranial nerve palsy. There was right-sided hemiparesis with loss of some initial milestones that he had attained earlier. He was also noted to have hepatomegaly. His complete blood count showed a PCV of 27%, a hemoglobin of 8.9 gram per dl, white blood cell count of 10,400, with neutrophilic component of 36.6% and lymphocytes of 53.5%. Platelets was 540,000. The serum renal function test revealed hyponatremia. Sodium was 133.8 millimole per liter. Other parameters were within range. His platelet count has been on an upward trend and all within normal post-surgery. He was commenced on intravenous dexamethasone. PCV was optimized with packed red cells, and then phenobarbital was gradually weaned off, and he was commenced on oral levetiracetam. It was continued on intravenous ceftazidime as commenced from the neurosurgical facility. It was also reviewed by the ophthalmologist, and there was no damage to the optic nerves bilaterally. It was advised to use an eye patch and give the eye time to heal on its own. While on admission, he had regular physiotherapy sessions post-operatively. It was a one-on-one nursing care with strict monitoring of his vitals and input and output. He continued on supportive and specific care as already highlighted above. Dexamethasone was discontinued at 6 days post-second craniotomy, and it was commenced on oral dexamethasone, which was then discontinued on day 8. He completed 10 days of intravenous antibiotics and then was transferred to the ward at 8 days post the second craniotomy and was later on discharged on the next day. He has been stable and is recovering well at home since then. He's still on physiotherapy at home. He's gradually catching up with all of his developmental milestones in comparison to his other twin. So that's the end of my case summary. Thank you so much. Okay.
Thank you very much for your presentation. Professor Temia is not able to join because of network issues. He reached out to me. So I will call on Dr. Akinsete to please go ahead with your presentation. Thank you.
Hello. Sorry, my network is failing. I just joined again.
Go ahead, sir.
Good afternoon. Please, can Dr. KAYODE please help me share the slides? So, good afternoon, everyone. I will just, over the next 6-7 minutes, run through symptomatic thrombocytopenia and astrocytoma. So this young man that we've just listened to presented with thrombocytopenia and signs of dysfunction with regards to platelets. And incidentally, along the line, we imagined he had a cerebral bleed, and then it turned out that there was something more sinister than the cerebral bleed. So next slide, please. So we all know, just a quick overview of what platelets are. We know that amongst Africans, we will say that the counts will be between 150 to 400,000. Now, platelets are quite small, and they are unique in the context of the fact that they help us to keep blood within the confined space. And whenever we have certain injuries. Platelets are the first one to go there to initiate some form of hemostasis. Now, the bulk of the platelets in the body are actually circulating in the bloodstream, but a third of the platelets reside in the spleen. And that is why for patients with chronic immune thrombocytopenia, splenectomy offers some ray of hope. Next slide, please. So we're just looking at what are the qualitative and the quantitative causes of thrombocytopenia. So this boy, at the first time we saw, a 7-month-old who presents to us with a platelet count of 8,000, and he was otherwise well. We would think thrombocytopenia, but at the time of presentation, he had a fever. Now, when we look at literature, most cases of immune thrombocytopenia, at least in the acute setting, would occur after the fever and the pyrexia may have settled. So the question is, why does this 7-month-old have thrombocytopenia and presents with evidence of mucosal bleed? So we know he has thrombocytopenia. So it's a quantitative problem. When we look at the quantitative problems, is there a problem with decreased production, in which case there is a hypofunctioning of the bone marrow? Is there a factor of increased destruction, which immune thrombocytopenia will sit within, or even infections, because this boy had the fever? Has he used drugs that have a predilection for causing lysis of platelets? So those are the things we would look at when we review the boy. But because apart from the temperatures that the mom complained about, the documented temperatures at the health facility were not febrile. So we would err on the side of this is most likely immune thrombocytopenia, but let's watch him and see how he does. Now, the qualitative problems that have to do with thrombocytopenia are not particularly common in this age group. So we were going to stick with the quantitative problem and we will review. Now, he comes back some days later, 2 days later, and the platelet count was already recovering. So we believed in our hearts that, okay, this was most likely immune thrombocytopenia. However, by the third time he presented in the health facility, despite an improvement in platelet count, he was having more severe bleeds. So the question is, do we have a form of thromboasthenia in this child, where he has somewhat improving platelet numbers, but functionally these platelets were not optimal? So those were the thoughts in the mind. Next slide, please. So looking at literature, infantile immune thrombocytopenia is not common. And so if we look at this child, the largest series was the one from Iran by Farhandi et al. And they looked at 187 children, infants now, between 2004 and 2011. And they concluded that the risk of ITP was commoner amongst children between the 3rd to the 6th month of life. So this boy fell somewhat in that cohort. The other thing was that Farhandi's review documented an association between the use of vaccination and infantile immune thrombocytopenia. Interestingly, when they reviewed the vaccines that they had, the use of DPT, diphtheria, pertussis, and tetanus immunization was strongly associated with immune thrombocytopenia in infancy. The other vaccine that was associated was hepatitis B infection vaccines. So this particular boy had the vaccine, DPT, a month to this episode. So is it possible that it was the DPT that precipitated this immune thrombocytopenia we're seeing, since it's been documented in literature? Now, in Farhandi's series, he didn't find a sex predilection, but every other worker that looked at infantile immune thrombocytopenia said that it was commoner amongst boys. Now, in most of their series, there's good response to steroids. However, 45% of the children will spontaneously begin to recover, which is what is common with immune thrombocytopenia. Intracranial bleeding, interestingly, was not very common. And that's what we find in immune thrombocytopenia, that intracranial bleeding is not common. It's less than 2% in the Farhandi series. For the one by Dewang et al., they had 0.5% intracranial bleed. So we see that even though this child may have immune thrombocytopenia, intracranial bleed was not common. So when he presented again with signs of altered sensorium and increasing intracranial pressure, we were almost certain that this was a bleed. And the transcranial Doppler revealed that he had a bleed, which was confirmed by CT. Next slide, please. So now the challenge was, literature does not support intracranial bleed in the setting of increasing platelet count. So that was where the problem came up again, that once platelet counts begin to improve in children with immune thrombocytopenia, you don't expect an intracranial bleed. You may still have 1 or 2 mucosal bleeds, but you won't have that. Now, this chap had platelet counts going up to 29,000, and he had an intracranial bleed. So we had to look at something different. And that's where the astrocytoma thankfully came up from the MRI, was confirmed by the MRI, and was confirmed at histology post-resection. So when we look at thrombocytopenia and astrocytoma, what's the common thing there? Astrocytomas, the commonest is the pilocytic, which is a low-grade glioma. In literature, almost all that have been reported in literature have been cerebellar pilocytic astrocytomas. We haven't seen a case of an astrocytoma in the cerebral cortex which was bleeding. So this may actually, until we still get more extensive literature here, be the first documentation of a cerebral astrocytoma, pilocytic astrocytoma with hemorrhage. Astrocytomas can bleed, and Don Fryo et al. Looked at astrocytomas over a period of time, reported in literature from different areas, and they try to ascribe mechanisms why there is intratumoral hemorrhage, from structural abnormalities to new vessel development. Maybe that was what the child had, and that was why the bleeding was potentiated despite improving platelet count. And after the apheres platelets have been on an upward swing. So the summary for us is that causality and relationship to ITP with regards to astrocytoma is still work in progress. However, we do know that astrocytomas bleed. We also know that children at this age can have immune thrombocytopenia. So those two things may have coexisted in this 7-month-old infant now. And that was why he presented to us the way he presented. So references are available. Thank you very much.
Thank you very much, Dr. Akinsete, for that concise presentation. Obviously, it's an interesting case, and I hope that there will be more questions and discussions after the next presentation. I think the next presentation is Dr. Joe. So I think we should just go ahead and take it, and then we can go on to discussion and questions. Thank you very much. Dr. Joe.
Good afternoon, everyone. Teachers, medical elders, ladies and gentlemen. I will be presenting the next perspective to this case. Okay. I'm presenting the pediatric approach to care. The title of this, the subtitle is The Approach and Challenges of Managing Thrombocytopenia in a Child with Serious Underlying Illness. My name is Dr. KAYODE Olamide Valentine. I'm a consultant pediatrician neonatologist with Pediatric Hospital Lekki Phase 1. I'll be presenting under the following headings: introduction, etiologies, and other ones are projected here. I will not dwell too much on platelets because Dr. Akinsete has actually talked so much about platelets. But importantly, we know that a single megakaryocyte can produce up to 4,000 platelets when they liberate on maturation, and lifespan is about 10 to 14 days. Of course, platelet plays a lot of role, but majorly platelet plug formation for the vessel wall. They provide catalytic surface on which coagulation takes place, leading to thrombin formation. They also help us to do what we call clot retraction because of their cytoskeleton and contractile protein. I won't bear much here again because Dr. Akinsete has taken this about thrombocytopenia in children, but also in neonates, they can have as low as 120,000 cell per millimeter cube platelets. How we can all hear me, please? How about me heard?
You are loud and clear, sir.
Thank you. So for us in pediatrics, when we look at thrombocytopenia, we want to look at it as an iceberg theory. The iceberg in which the tip of the iceberg is being seen by the sailor when they are coming, and if they're not careful, it can wreck them if they don't look at what is under. So in the analysis of thrombocytopenia, we categorize that as majorly disruptive or consumptive one, impaired production, or sequestration. Pediatrics actually made mention of these things, but just to remind us that for pediatrics, we look at the neonatology part and the young children and the older one in approaching them. Majorly, we look at immune thrombocytopenia and non-immune. Most of the neonates can have perinatal asphyxia related to thrombocytopenia. They can also have perinatal infection related to thrombocytopenia. Trisomies can also affect them to produce thrombocytopenia. For non-immune cases, it's probably majorly infection like bacteremia, fungemia, protozoa like malaria can give that. Other thing related is neoplasia-associated immune thrombocytopenia and HIV-associated one. Very important to state that an heparin-induced thrombocytopenia has been documented and is very common, and care to be taken when we are flushing our patient's line with heparinized solution because of this. Allergy and anaphylaxis can also do this can cause thrombocytopenia. For impaired platelet production and hereditary things like thrombocytopenia after reduced syndrome, TAR syndrome, viscohydric syndrome with current eczema, S-link problem with thrombocytopenia has been noted. Other thing that we have concerned about is medications for acquired cause of impaired platelet production. Anticonvulsants have been implicated, so that's why patients on anticonvulsants are actually on follow-up of their blood work to check all these things. And we know that in sickle cell anemia, we talk about sequestration crisis. For platelets can be sequestered in hypersplenism, hypothermia, burns, or hemangioma. Beyond that, this patient that were under review, the diagnosis that came to fore when we saw was immune thrombocytopenia purpura, ITP, initially called idiopathic thrombocytopenia purpura. The term is no longer used because immune mediated has been demonstrated, so that has been jettisoned. So now it is immune thrombocytopenia purpura. It's a common diagnosis, and that was what we thought our patients had initially, because it can happen in 120,000 children about 1 to 4 weeks after a viral illness. The mother of this child had a viral illness a week before that time. However, like the check showed us, there was fever that was documented at home, not in the hospital. In the analogy of ITP, early infancy to elderly people are the commonest cause. So this child was fed into infancy period, but the peak of ITP is 1 to 4 years. That said, the exact identity target for such antibodies that will occur in people with acute ITP is undetermined. But for chronic ITP, we realize that there are antibodies against the glycoproteins on the platelets, and these antibodies are recognized by the F receptor or the spleen macrophage, so that when the platelet gets to the spleen, they are ingested, identified, and destroyed. That is why anatomy is very important for those that have chronic ITP. Viruses can be associated with this thing like Epstein-Barr virus, HIV, bacterial pylori, and really following vaccine. Our patient had vaccine a month ago, and one of the vaccines with a DPT, he had extracin vaccine. That said, what are we looking at when we are approaching the child with thrombocytopenia, especially the ITP that we are looking at now? The child that came classically like that, although it's less than 1 year, but was previously LD, with sudden onset of generalized petechiae and purpura. Now, this is a concern for what we call non-accidental injury in children. If a child comes to the clinic with such generalized petechiae and purpura or bruising, people will think that, oh, as a child been abused or beaten at home, but the care should be taken to look at other things that can suggest abuse, because ITP can occur suddenly. So that's one thing about ITP. Other things that may be noticed is that platelet count will be less than 50,000, though they will not be bleeding. But in the profound thrombocytopenia, the platelet count will be less than 10,000. However, splenomegaly, venopathy, bone pain are rare presentation in ITP, and therefore means that if we find splenomegaly, venopathy, bone pain, and pallor, it is not likely to be ITP. Our patient did not have these symptoms. In the classification of when you want to classify and the type of bleeding in such patients, when you're approaching them, you look at UK staging that talk about this bleeding severity, not platelet count in this time, and stage 1 that no symptoms, And that's stage 1. In stage 2, there's mild symptoms, there's bruising and petechiae, occasional minor epistaxis, and very little interference. So the child does not have any problem with daily living. Our patient was in that stage 2 where we were seeing until it became later moderate symptom where there was more severe skin and mucosal lesion. There was no epistaxis, however. For those that are adolescent patients, they can have menorrhagia, epistaxis, but then one is severe, and that is stage 4. Less than 1% of patients can actually present with retinal hemorrhage when they have this, which is very, very rare actually. And for outcome and approach to ITP, when you manage ITP, we want to actually look at is the bleeding severe, which is actually rare than 3% in most of the studies. However, for acute ITP, about 78% of children, we actually have resolution within 6 months, and our patient did have that. The illness started for within 16 days, and everything was resolved within those 50 to 42 days, which actually put the child on the acute immune suppressing purpura. Another thing that we actually approach is that therapy, it been said that does not actually affect the natural history of the illness, and this has been a major consensus and argument for when to intervene. But proponents of interventional therapy says that if a child has treatment less than 10,000, we should optimize the child to up to more than 20,000. This child was actually being planned for optimization when he bled on return, and that could actually prevent the real rate of ICH, although there are also arguments against this and transfusion when there is no bleeding. That said, findings laboratory-wise said about Thrombocytopenia being actually profile less than 20,000, the HB may actually be normal if the child has not had much of the bleeding. However, when the child has actually bled so much, you have actually low PCV. However, if you check the bone marrow, they have normal granulocyte and red blood cell series. That means the precursors of red blood cell and white blood cell are normal. However, we will do bone marrow examination for any child that has thrombocytopenia if they have unusual presentation like abnormal white blood cell, if they have unnecessary anemia, if they have suspicion of bone marrow failure or malignancy, or HIV-related effect that is severe. That point, you may have to do bone marrow. But usually, if it's an ITP that is classical, they do not require to have a bone marrow aspiration or biopsy. Neuroimaging is actually indicated if there's suspicion of bleeding. Our patients had neuroimaging when we realized that he was vomiting at that point of care. How do you care for ITP, which we're trying to do for our patient? There's no therapy for those that are in stage 1 and stage 2. Stage 3, when they actually have mucosal bleeding, you may actually have to give them intravenous immunoglobulin, 0.8 gram to 1 gram per kg. They can also be on steroids for that. However, if a child actually bled, then it becomes a multiple modality with ICH. And that was our thought when the child actually showed evidence of bleeding, we had to actually commence steroids and prompt neurosurgical consults. Splenectomy is advocated for chronic ITP. Our patient did not get to do, we have not got to that level because by 42nd day of post-op, the platelets have actually become normal. What can we consider when patients have ITP? Like I earlier said, if there's hepatomegaly, bone or joint pain, remarkable neuropathy, all these signs say that is not ITP, that we should look at other things like leukemia, hemangiomas, congenital anomalies, and such things like that. Then we look at the child's wellness or illness. A very ill child actually would suggest something like microangiopathic problem like HUS, DIC. This is one of the babies that have an infant with Tourette syndrome. Those are the things that we're looking at if you are evaluating children or babies with thrombocytopenia. So approach to care. A detailed history or clinical state of the child, is it well or ill? Age of the child is very important. We see that in race, Black people may actually hide petechiae and purpura, whereas white babies would not do this. It's very important to take note of the patient pre-morbid state. Is there any anomaly subjected, any anomaly that is looked into? Our patient under review had uninvestigated infant obesity. Now, this is very controversial because the child was 6 months, but his parameters were actually eating more than 97 percentile. It's difficult, especially if the child does not have milestone problem, which the child never had, or any other pointing signs like patient with Prader-Willi syndrome or Cohen syndrome or Carpenter syndrome. All these patients will have things like milestones that affect that will actually prompt an imaging and other investigation. Our patient was actually doing well to that time. And the thought was that, oh, okay, 7 months, let's see what happens before 1 year. And so this actually kept us on our toes that sometimes if a child has infant obesity, we should actually interpret the OFC carefully because macrocephaly can be hidden under obesity. That cell, further approach in care include protocol of care for the team. There must be protocol of care. Our team actually work on the protocol, and one of the fear of that protocol of care is that if you give platelet to a child that has ITP too early, they may actually, the platelet antibodies may actually get on that transfused platelets and lyse it further. And so protocol of care is very important, and parents need to actually be involved so that when they say come tomorrow, come next tomorrow, they are not thinking that what are we going to do. The parents of our patients are actually very cooperative. They were coming and we're actually in communication with them. In fact, the last session was because we called and they said he vomited, and I said, please bring the child in. Again, there should be no assumptions. There should be an institution of care. And it is part to state that childhood illness do not write textbooks. What we read the textbook sometimes, like what we are seeing now, is that we're actually surprised that this was not just an intracranial bleeding. So illness in children do not write textbooks. We need to actually individualize care for the children and not to underestimate what we call the multidisciplinary approach. Pediatrician, hematologists, surgeons, they may need to be involved because they can actually have intra-abdominal bleeding besides intracranial bleeding. This is a picture of a child, of a black child and a white child. You can see the petechiae obvious in the white child and those one eating. Challenges of this case and confounders. This child presented like a classic ITP as an apparent pathology, and we managed as such initially. Unfortunately, international consensus to prove that when you provide intervention before bleeding is not adequate. So there is no consensus that you must transfuse before a child has bled. But there is a consensus that you could actually start them on intravenous immunoglobulin or steroids, which was being planned at the point that the child bled. Of course, I talked about black race, searching for petechiae and population was a big problem. But when the patient came, we have to be counting because it's actually a black child. So we are trying to count and see as he increased in number. The mother too was also helpful. Like I mentioned before, the fear of antibodies getting on the transfused platelets is making a consensus not to be agreeable on transfusing them ahead without knowing what the diagnosis was. Now, to the meat of the matter, Astrocytoma and acute thrombocytopenia, is there any association? Now, literature, like Dr. Chita has actually pointed out, showed chronic ITP in adults, and actually a few. But we have an 8-year-old American girl who had chronic ITP from 18 months of age and did not develop any bleeding until she was 8-year-old when he bled into an astrocytoma. At this point, the child actually had spent a longer time without any sign of tumor. And so for that child, he had a chronic ITP before the tumor. And there is a suggestion of what we call solid tumor serving as a target that trigger platelet antibodies. This is a theory that is actually being proposed. Again, our patient is an infant. And up to date, there is no documentation of any infants with pediatric astrocytoma having acute ITP and bleeding to the brain. We've not seen that till we are still searching. Again, in this our case, the thrombocytopenia resolved after the surgery. The platelet count actually rose. So the all illness and surgery about 16 days. But by the time the child was coming at 6 weeks, platelet was already 450,000. So the child actually recovered from the thrombocytopenia after the surgery. Meanwhile, in the case that we're talking about, the 8-year-old American girl, that child never recovered after the surgery was done, and she had penectomy again after having a brain surgery. Our patient was lucky that he recovered after the surgery without need for planning of any other adjunct therapy. Point to ponder, it would seem that this child astrocytoma has been ongoing before this ITP became symptomatic and brought to our attention. To think otherwise is actually plausible, but not convincing, because the duration of thrombocytopenia was about 16 days, and the tumor could not have grown within 16 days. We have to note that when a child with ITP presents with features of intracranial bleed, we must not just put it that it is due to the low platelets. We must actually try to look at other things, which was actually surprising at this child presentation. This case therefore points out that there is importance of arranging detailed intracranial imaging in a case to look for other underlying causes which may require separate management when we suspect that there is maybe a bleed that may not only be because of the low platelets. And that will actually make us to have what we call the quick interspecialty transfer. These are the references. Thank you so much for your attention.
Very much for the time. Sorry, I swapped your name at the beginning. I hope you can hear me because my network is very bad today.
I can hear you now, sir.
Okay, thank you very much.
You're very clear, sir.
Okay, yeah. All right, I think we are in the question and answer time.
Dr.
There's one more question by Professor
Dr.
Oh,
yeah.
Oh, Dr. Joe has not presented.
No, it's the last question, sir, that we're taking. And then there's a comment by Dr. YJ before.
I thought you had presented. Okay.
So we still have two people talking, Dr. Ojo and Dr. YJ.
And Dr. Ojo, please present now.
No, stop. Hey, stop.
Please, let's mute our microphone. There's a lot of background noise. Please, let's mute our microphone. Dr. Ojo, please. All right.
Sorry, can you put Dr. Joe's presentation on a slideshow so that will be clearer? Just put on slideshow. Thank you.
Dr. Joe will start in a few minutes.
Okay. That's all right.
But can we put his presentation on slideshow so that it'll be clearer for us to be able to follow?
Okay.
Just put on slideshow. Thank you. Okay, that's great.
Is it better this way?
No. It has to be on slideshow. We can see everything, but it has to be one after the other. The way you did yours, yes, this is good. Great. Thank you.
Okay. All right. That's okay. I think it's on slideshow now.
Yes, sir. It is.
Yes.
Just a minute, it's joining soon.
Please, can you hear me?
Yes, please.
Yes, we can hear you.
Thank you. Apologies.
Dr. Ju, your mic is muted. Okay, you're on mute now. So,
okay. So, when it comes to thrombocytopenia, especially in neurosurgery, well, we are always very careful of the platelet count. So routinely, we need to check the platelet count to make sure it is compatible or it is safe to go ahead with the surgery. And the basic is to rule out coagulopathy, because with thrombocytopenia, the consequences could be very severe, which may be severe bleeding while operating. And in such cases, it will be very difficult to stop the bleeder. Sometimes we are fortunate we may be able to stop the bleeders, but there may be recurrent bleeding, the reactionary hemorrhage. And all of these will lead to raised intracranial pressure. So thrombocytopenia per se, it's not an absolute contraindication, but in many instances, it could be absolute. And also relative at other times, most likely. The causes, I'm sure we all know, a lot of it has been discussed already, medical, but we know that in some cases, it is associated with pre-existing tumor. So a tumor with thrombocytopenia can bleed, and also tumor on its own can lead to intracranial hemorrhage. Basically, spontaneous intracerebral hematoma is associated with low platelet count. So when the platelet count is about 50,000, we tend to see spontaneous intracranial hemorrhage, which could be the start cause. I looked into the literature, especially looking out for the causes of intracranial hemorrhage in patients with tumors. And neovascularization has been implicated as new blood vessels are being formed. Some of them are not matured enough and can bleed. More so, there could be infiltration of the tumor itself or the tumor vessels into the parenchymal blood vessels. At different points, it may bleed. The clinical presentation of intratumoral hemorrhage is not distinguishable from spontaneous ICH. So if we don't know, we may confuse one for the other. Next slide, please. In the literature, like I mentioned, it's been documented, but the particular reason why it happens is not has not been clearly explained. But we know that in patients with meningioma, in patients with pilocytic astrocytoma, and more particularly in patients with GBM, in about 5 to 8% of intracranial hemorrhage, they will be associated with GBM. Hemorrhage do occur also in low-grade tumors, particularly at pilocytic astrocytoma, but usually it is a high grade that we see such. Next slide, please. Subarachnoid hemorrhage has been linked to pilocytic astrocytoma. I must say at this point that it's especially rare to find pilocytic astrocytoma as being associated with thrombocytopenia or being associated with intracranial hemorrhage in general. But it is rarely so to find it in a patient that is as young as this patient in question. In cases that are in the literature, there was a girl with 31-year-old girl. There was another one who was about 50 years old. So it has not been very reasonably documented in younger age group. Next slide, please. So now that we know that cranial tumor can bleed, thrombocytopenia can lead to intracranial hemorrhage as well. When we look at the patient in question, it's more like a double whammy. For instance, we found a tumor. I'll talk more about that later. But when he presented to me, it came basically because of the thrombocytopenia, which had been diagnosed with, had some FFPs and had this intracranial hematoma. And at that point, I wasn't sure it was a tumor. Next slide, please. So for intracranial hematoma, especially when it is large enough, one will have to evacuate it. But when this patient has coagulopathy, then it becomes a concern and one has to take calculated risk. Basically, in patients that are not emergent, one may have to talk about correcting the coagulopathy. But when it is not possible, it has to be done en route to the theater, bearing in mind the risks that are involved. Next slide, please. Next slide. So this is the image of the boy. We can see the lesion on the left, which will be the right as we look at the image. It's quite large and it has some hyperdensities. And this was reported as intracranial hematoma or intracranial bleed. But we look at it carefully, we could see that there is a well-circumscribed lesion, more like a cystic cavity with a bleed inside. So when I was planning for this, I thought of removing it anyway, but I knew looking at it, the intracranial pressure must be very high. And when I opened the brain, when I took away the cranium, the brain fungated immediately as if toothpaste was coming out of the tube, and I had to quickly decompress it. What that meant then was that the brain was under severe intracranial pressure. Next slide, please. The indication for surgery for either intracranial hemorrhage or brain tumor of any source, particularly in children, would be The neurology, lateralizing signs, particularly if the patient is rapidly dropping in GCS, and that makes it an emergency. Raised intracranial pressure could be diagnosed clinically or by looking at the images. And this boy fitted perfectly into all this. He had lateralizing signs. He was weak on the right. GCS was low. He was a bit drowsy, and I could tell that the intracranial pressure was high. Next. So, bearing in mind the double whammy this patient had, raised intracranial pressure, thrombocytopenia for which the platelet was being corrected. If we didn't do anything, the boy would have passed, and he would have passed so easily because by the time I got there, like I mentioned, the pressure was so high. Doing something was the only way we could have given him any hope at all, and otherwise there wouldn't have been a future. So we decided to go ahead, despite the fact that the platelet was low, but it was being corrected. Next slide, please. So, looking at the image, one had to make the diagnosis. Is it a pure intracerebral hematoma, or was it intracerebral hematoma associated with brain tumor? Anything short of adequate preparation will end in disaster. Next slide, please. So the decision was a bit challenging. For basic intracranial hematoma, a borehole would have survived, meaning we make a very small hole and suck out the hematoma. For tumor surgery, we have to have the tumor in perspective, so we have to make a very large opening. And after the surgery, one will need to repeat the scan to see if there were residuals. In this case, we repeated the scan, and we scanned after the surgery, and there was residual. We had to go back the second time. The histology showed pure necrotic tissue. My take from this would be that the hematoma had been there for a long time, and had probably hidden the tumor up. So what we saw was necrosis, or necrotic tissue. And after the surgery, he had to go for the critical care unit. The important fact here is that if the surgeon missed the diagnosis, it will end in disaster. Next slide, please. So prognosis is good, but it depends on the time or the state, the clinical status of the patient at presentation. If the patient was moribund, it would have been difficult to get involved. But a patient who presents early will have a better prognosis. And of course, the completeness of resection. Pilocytic astrocytoma will go back if not completely resected. And there is a case in the literature of a 51-year-old who has had the tumor resected, I think, about 4 or 5 times until he had to bleed into it again. So we have to ensure complete resection, and we have to do repeat scan to be sure that it's not going back at some point. Teamwork will make the prognosis better with the official, neurosurgeon, critical care unit. And when we put all this together, then we can save as many people as we present early. That would be the perspective from a neurosurgeon. Thank you.
Thank you very much, Dr. Ojo. I think now the floor is open for questions.
Sorry,
And
excuse me, sir.
Is there anything else?
Yes, Dr. Waji is supposed to just make some comment before we open the floor, sir. Thank
you.
Okay.
Okay. It's not here. Okay. All right.
Thank you very much, sir. Thank you so much, everyone. My name is Atinuke Owaje, and I just want to say a huge thank you to all of our external consultants. Yes, this child presented to us at Atlantis Pediatric Hospital, but it was the quick intervention with our hematologist. Dr. Joe was fantastic because I called him Sunday evening of what we saw. We were able to get apheresis platelets as early as Monday, and by Monday evening, he had already operated on the child. And again, this is just, it just tells us what we can do when we're able to collaborate both private and public institutions. And more importantly, for us as pediatricians, that those anthropometry measurements, they go a long way. And, when we looked back now and saw how big this child's head had been, even though he was meeting his milestones, and I guess what really distracted or didn't make us to think seriously that maybe we should have done some form of intervention earlier was the fact that his height and weight too, he was obese. Everything was over the 97th percentile. But, this is just a call out to all of our pediatricians that these measurements, they do matter, and we should also interpret them so that we're able to do more for our children. Thank you so much. Thank you, everyone.
All right. Thank you very much for your comments. Well, I think it calls for all of us to be vigilant at all times. And sometimes you have to think out of the box when you see some of these cases. Otherwise, one will miss them. All right. Now it's time for question and answer, further comments on the case. The floor is open, please. Any comments or clarifications? Well, personally, I think this case is quite interesting. It's something that one could have missed when you are not really thinking about what is happening. And I'm still racking my brain. Is this thrombocytopenia an incidental finding? Or was there so much bleed, like Ujo said, that there was consumption, coagulopathy within the tumor? I don't know whether we did the coagulation profile of this. I missed that period when we are presenting the case. I don't know whether the coagulation profile was done and whether it was normal or abnormal. At that time, if it had been presented, I'm sorry, my network was very bad at that time. So it's quite challenging, but we thank God that we're able to get to where we go to. And one has to remember from time to time that there are exceptions to the rule in these kind of cases. Was that coagulation profile done? Sorry if I missed it. Sorry to call you back.
The coagulation studies were done. They were all normal. They were all within normal. Because I think the first day that he presented, all those were done.
Okay, that's great. Okay.
There is a hand up. Hello, Dr. Timie.
Okay, hello. Can I, sorry, not Timie now. Can I call in? Come in. Am I being heard?
Yes, sir. You can go ahead, sir. You can go ahead, sir.
You can go ahead.
This is William Ogala. My friend there and colleague and a very good friend, Dr. Lawal, at the beginning was, I think he was excited to say, is that Professor Ogala? I was trying to answer, yes, sir.
Yes.
But then my system was refusing me to unmute at that time. I was quite embarrassing. The whole of Dr. Lawal was asking, and I didn't answer. I'm sorry about that, Dr. Lawal. But it is me, as you asked. I'm here. Thank you very much. I'm very happy that I connected to this program this afternoon. The issue of thrombocytopenia in pediatric practice. I'm so thrilled that the issue was immediately discovered and sorted out. Yes, we know that we have always known that in most malignancies can cause thrombocytopenia either by themselves or by the treatment that is being given to the malignancy. But I have not really I can't remember seeing one that the platelet had gone down to 9 as it went at this point. If I remember that sometime I went out of, I think I did hear 9. And and then to know that this was caused by astrocytoma, intracranial astrocytoma is again very interesting and very exciting and very bringing about a high knowledge here in our pediatric practice. So as I said, I'm very happy that I connected. The other thing I would like to say, I'm talking from from the north of the Niger. I'm excited about that surgical intervention. Really, really decently, quickly. Sometimes the idea we have for surgeons is that we have to look for them for days, sometimes days before they come, and by then the child is deteriorated and so. But this one, so much very quickly, and intervention, clean intervention. I note that at first the tumor was not completely taken out, and then later on went in again and got it out, and then the whole thing was sorted out. I'm impressed by these presentations this afternoon. Thank you for those who took us through the issues in thrombocytopenia, and as I said, I repeat, I'm happy that I joined this program this afternoon. Thank you, and God bless you.
Thank you very much, sir, for comments. It's great to see you, to hear from you again, sir. We appreciate you and the weight of knowledge you've brought in. Well, I think Dr. Joe, like Dr. Wadi has already has said, is quite reliable. When we need him, we get him, and we do what is right almost all the time. We thank God for his life and for what he's doing for us. Any other comments? Is there any hand up?
Good morning here. This is Professor Grinch.
You are welcome, man.
Yeah.
Good to hear from you, man.
I'm sorry I joined very late, but I'm sort of feeling quite excited to speak because of seeing Professor Gala. This is my first time of seeing him for many years, I think. So thank you very much. It's very good that you reached out to him, and I would like to encourage you to reach out to all the others whom we don't see regularly. Now, thank you very much, the presenter. That was great. I heard the last few sentences that you said, and as usual, you younger ones are really doing very good work. Thank you so much. I hope that many more patients are followed up in this way. What we hear is that people have lost the enthusiasm to really follow up cases, possibly because there's not so much money to be made these days from clinical work. Your patients are poor, and the environment is not so encouraging. But please just continue to press on. God will bless you all.
Amen.
We know you are working under extraneous circumstances. And I think when you write this up, you should always emphasize these circumstances, because you're achieving, wonderful results, even though you don't have such a rosy and resourceful environment as happens. So thank you It's lovely to hear you all. Thank you. All the best. And God bless you. Bye-bye.
Thank you very much.
Thank you. Thank you very much, Professor Gray. Quite a time. And thank you for the comment you made about me. Yes, we're around. I'm around. I'm around here in Abuja. I've settled here. You know that when I reached that level of age in Zaria, I decided to come down to Abuja, where I am now, and I'm so happy that I met you again this afternoon. And I just want to say that we thank God for it all, and will I say, may God bless us all. Thank you.
Amen.
Amen. Thank you very much, sir. We appreciate your comments and your encouragement. We'll continue to try our best despite the situation we find ourselves in. Thank you. Dr. Dusote,
Well, thank you very much. Yes, please. Thank you very much, Professor Temiye, for doing a great job to moderate this presentation. And once again, I want to thank all the presenters, like Professor Dr. Labola mentioned earlier. The collaboration, the teamwork is beautifully displayed in the mind of this patient. And I also hope that this will be reported in literature, like was counseled by one of our teachers, that should be written up identifying or highlighting the difficult circumstances where we practice. So this recording will be available on our YouTube channel, so you can always go back to listen to it, and you can also share this story with people in your network. It is very interesting, it's very insightful, and I think it's worth everyone in that space to listen to again and again. Until we meet next month when we have another interesting webinar, thank you for tuning in.
Just a minute.
Okay. I didn't see you. That's why I told you.
Just a minute. Yes. Just a small comment. Thank you very much. I want to thank everyone for your presence and for your participation. I'm very pleased, Professor Gala, for hearing your voice. I knew you were there, and your words of encouragement are very, very good. I also want to thank Professor Grange for her own words of encouragement, and to thank everyone for participating and for your comments and contributions to this meeting. I think the lessons of today's presentation are very clear, and they have been mentioned by everyone in terms of being prompt, in terms of considering our patients as persons, and sometimes they may present with certain symptoms. Let us not look at symptoms alone. I've seen situations where people are actually treating laboratory results instead of looking at the whole patient. And as Dr. Waje mentioned, all these anthropometric measurements that we take, head circumference, height, weight, and so on, they are all important. And if we see something that is not adding up there, then we should actually be going after them as well, apart from presenting complaints, because sometimes there are red herrings. And, the patient comes in, and this case is so interesting from so many aspects. Also from the aspects of, I think Dr. Valentine mentioned this. I noted it in this presentation where he mentioned about anticipation and no assumption. I think this patient was saved because of a presence of mind and anticipation, clear anticipation on the part of the initial facility. And our desire is that every facility, every place where children are being looked after, we'll be able to function at the level at which the Atlantis Pediatric Center has functioned on this particular occasion. So congratulations to Atlantis Center and the surgeon, Dr. Ojo, and all the other people who participated in the care. Thank you all very much. Over to you, Dr. Dusote.
Thank you, sir. For everything you are doing to continue to lead us in the right direction with this organization. So, like I said, until we meet next month for an interesting webinar, like I also mentioned, this recording will be on our YouTube channel and many other past recordings. So you can also, it's a good resource to actually ask people to check out for past presentation and the current one. So see you next month. for another interesting webinar. God bless.
Thank you, sir.
Thank you, Tunde.